our CT scans, we can see that some of our radiopaque graft material is disappearing. And what we seem to see here is like a black hole in the middle of our sinus graft because the graft is being resorbed through the infection process. Now, we have to think about what the etiology of these infections might be, and we have a couple of major factors. One of them would be preoperative, pre-existing sinus infection or disease, and that's really a very important thing. And there's a concept called sinus compliance. Sinus compliance means the ability of a sinus to react to the trauma of your surgery, which is really an inflammatory event. If the sinus is healthy, it's considered to have high compliance. You could do your surgery and nothing major will happen. If the sinus has some kinds of pathology, very thickened membrane, some inflammatory disease, it has low compliance. And you just looking at it the wrong way will cause a post-operative problem. So you always want to make sure that your sinus is healthy when you start, okay, that it can handle your surgical procedure without a problem. We also have to look at surrounding problems around the sinus that may affect it, like periapical pathology near the sinus floor. If you have periapical pathology on a premolar near the sinus floor, you place a sinus graft, that graft will become infected from the infection on the premolar. So we have to take all of these things into consideration. And the final thing is the chain of sterility and how you keep the area that you're working clean. It can't be sterile. Your equipment can be sterile. Your bone graft can be sterile. But the mouth is not sterile. You have to keep it clean and keep the bacterial load as low as possible. And you have ways of doing this. You know, we can think of a couple. When I set up my surgical tray, I have one tray for my instruments that I use in the oral cavity. I have another tray for the instruments that I use inside the sinus. And I never let them cross-contaminate. I also have suction tip for the mouth, different color suction tip for the sinus. So keep everything separate. I have all my graft materials ready to go so that nobody has to go get them from somewhere else, and that's cross-contamination. So I have everything there. And again, we talked about when you place your graft material, not allowing for salivary contamination. So if you do all of these things, you know, you are going to pretty much have that 1% of cases that you have a problem with, and no more than that. I talked about starting with a healthy sinus, but if you look at these studies, these are CAT scans that were taken of groups of people, and if you look in there, about 40% of all patients have some kind of sinus pathology, even though they are clinically symptom-free. Now, not all of these are a problem when you're doing sinus grafts, okay, but some of them are. And you have to decide, are these things that should be taken care of before I do my surgery, or are these things unimportant? We talked about one, we talked about cysts. A cyst is only important about its size. So if necessary, we reduce its size. And you know, there are other things that you have to see and decide if there's problems. When you have periapical pathology like this, you have to remove the teeth because the lesion you see in the sinus is really starting from the apical pathology on that molar. This is an interesting case. I wish I could point it out to you. The sinus that has all of the clouding and pathology is due to those hopeless molars that are not even in bone. They're just completely floating, but there's a very small opening, okay, right into the sinus above that tooth and that panoramic film, and that's causing the pathology. How did we resolve this? We took the teeth out, put the patient on antibiotics and anti-inflammatories, and it all cleared up without any other treatment. This is sinus pathology from an implant, an infected implant that's in the sinus. That's causing the clouding in that sinus you see on the right side. Here, that sinus has got part of a tooth was sectioned, part of it wound up in the sinus. We have pathology, inflammatory pathology relating to that tooth fragment. So you have to look at the patient's history and decide whether this is a patient that should be treated or should be sent to an ENT for evaluation. I send very few patients over to my ENT because he's told me that I can do a lot of the things that he would do by myself. So it's a matter of getting a relationship with an ear, nose, and throat doctor and finding out what he wants you to do and when it's appropriate to send the patient to him. I'll give you an example. We talked about the cysts. So you see a cyst in the sinus, and a small one looks like this, and a large one looks like this. Then you've got one that's kind of right in the middle, medium size. Do you send it to him because you don't want to try to do anything with it? Well, I used to do that, but then he told me, why don't you just tell the patient that they have a cyst and that might give them a problem. And if it does, you'll send them to me to take care of it. So if you don't want to be, aspirating the cyst, but you think it might be a problem, you have to tell the patient beforehand, and then if it becomes a problem, then you send it to the ENT. But he should know what you're doing, because if he doesn't know what you're doing, the relationship might not work out very well. So when a patient has a history of low-grade chronic sinusitis, is that a patient that I would send to an ENT? Probably not. That's a patient that I would say, well, when are you healthy? Well, I'm not healthy in the spring because the pollen gives me sinusitis. In the winter, I'm fine. So I do the sinus graft when they don't have seasonal allergies. So you can figure out how to do that. If, however, you have a patient with a history of acute sinusitis, okay, that's a patient that you should refer to find out what the cause of that sinusitis is and realize that that's not a patient that you treat. Never would you treat a patient who had active sinusitis of any kind, because again, that's low compliance. They're already suffering. Whatever you do will make it worse, and it will make it worse very quickly. So start with the healthy sinus, refer when it's necessary, and realize that a lot of the problems you can take care of just with antibiotics and anti-inflammatories and extraction of a hopeless tooth. If you look at this case, okay, you can't very much tell anything from a panoramic, but if you look at the teeth, you can see that there's a problem in the sinus here, okay? So what do? Do I take a CAT scan to see what the sinus problem is? No, I know it's there already. I know it's related to the teeth. So what I should do is take the teeth out, put the patient on a combination of antibiotics and anti-inflammatory, wait 3-4 weeks, then take the CAT scan and see what I have. Because this is what's going to happen. If I take the CAT scan right now, take the teeth out, immediately take a CAT scan, this is what I'm going to see. I have a problem here, okay? But if I put the patient now with this patient, I then put them on antibiotics and an anti-inflammatory, and in 3 weeks, I put them on this combination of Augmentin and prednisone. And this declining dose of prednisone and the Augmentin twice a day. In 3 weeks, it looked like this. No treatment. It went from here with this treatment to here. So problem resolved. That's not an issue. Go right ahead and do my sinus graft. So we have to determine which antibiotics are the ones to use. Now, it may be a problem because they may call them different things here than they call them back in the United States, but we should be able to figure it out. The bottom line is that you have all kinds of bacteria that could be causing problems in the sinus. The ones that are normally found there, the transient ones, and the ones that come in from the oral cavity from infections. So you have to have a broad spectrum antibiotic that can resolve all of this. And the best one that I've ever found for any of this is Augmentin, amoxicillin with clavulanic acid. I'm sure you have that here, right? Yep, yes? Yeah. Amoxicillin with clavulanic acid. Okay, the best one. The only problem is if your patient is allergic to penicillin, you have to use something else, and then it's a problem. So if I have my choice, this is what I'm using. And I have never had a problem with post-operative infection when the patient is on Augmentin. And I start before the procedure. I usually start the night before with the first pill, and they're one in the morning and the evening for 10 days. Now, some people consider that over-medication. There are some people that like to use the same protocol that they use for putting an implant into the patient's natural bone, which is the patient comes in the office and they give them 1 tablet of amoxicillin. Well, if you do that, your infection rate on sinuses is not going to be 1 to 2%. It's going to be much higher. Because anytime you're using a bone graft material, you have to take greater precautions. So Augmentin for 10 days is the perfect thing to use when you're doing the sinus graft, and you'll have very good effect results. Now, there's an antibiotic called clindamycin, which has always been used in sinuses for people who are allergic to penicillin. It's in many textbooks. It says that it's the one to use. If you remember anything that I tell you today, remember that clindamycin absolutely does not work in sinuses. It's useless. It does nothing. I don't know why. It's an antibiotic that has a very high blood level, but in sinus grafts, it has turned out to be useless, not only for me, but for other people I know. And finally, somebody wrote a little paper 2 months ago saying that so many people have experienced this. So if your patient's allergic to penicillin, we have to find something else for them to use. So this is a list of all the things that are available to me. Okay, I have basically 2 families of drugs that I could use. One are the bacteriostatic macrolides, which is Zithromax, Miaxin type drugs, azithromycin. And the other one are the fluoroquinolones. Now, the fluoroquinolones, like Levaquin and Avelox, are fantastic. The problem is that the side effects of these 2 drugs are totally out of control. It was early reported that Achilles tendon ruptures occurred on people using this drug. Well, that's not so good, but that's not the end of it. They've now found peripheral neuropathies, cardiac problems, okay, gastrointestinal problems. You really can't use those 2 drugs on the bottom anymore without having the patient sign a waiver. Because if anything happens to them, you will get, in the United States, you will be sued, okay? No doubt about it. They're fantastic drugs, they kill everything, but they have too many side effects. So you must use something like the 2 up above. The difference is they are bacteriostatic as opposed to being bactericidal. So I always am a little bit nervous, but they seem to do the job. And again, I do 10 days, starting the day before. So that's my preventive precautions. If a patient gives me any hint that they have an infection, either a sinus graft infection or sinusitis, I immediately put them on a combination of drugs. And that will again be my Augmentin, but I'll add to that metronidazole so I can also get the gram-negative bacteria. I can't do a culture to find out what's wrong. It takes too long to get it back. So if I think there's a problem, I immediately hit it. It's much easier to treat these early than to wait for later. So I use my most powerful combination of drugs to go to work immediately, and then have to develop a protocol of what to do if this doesn't work. Okay, so we'll do that. And what I have is I have different stages of intervention. You know, so my first one is always an antibiotic thing. If I see that there's something going wrong, I'll put the patient on the combination of antibiotics. And there I can wait a certain amount of time, usually about 3 to 5 days. If nothing is happening, I don't expect it to happen, and I'll go on to a different stage. If I can see the infection in here, I can put in a drain and leave a drain in for 72 hours plus the antibiotics, and that will help a little bit more. If that's still not resolving the issue, I now have to do either a partial clean out of the graft material or a full clean out. And that depends on exactly what the condition is, and I'll show you an algorithm that we develop, okay, for treating these infections. So, I mean, here's a case where I did the sinus graft on the right, and it looks beautiful. It's a perfect case. Problem is, 10 days later, bit of swelling, and if I push on that, I get drainage. So what I did here is I reinstituted a different antibiotic and put in a Penrose drain. The drain is not in the sinus, the drain is just underneath the soft tissue to facilitate drainage. I leave that in for 3 days, take it out, and you can see here in the radiograph the drain in position, and you see the inflammation over the top of the graft, which wasn't there back here. Look here, perfect graft, clear up above the top, okay? But when the infection occurred, we go back to this one, you see over the top it's all clouded. So we put the drain in this case, and in 10 days it cleaned up. 3 weeks after, those symptoms or signs, and if you look at the radiograph, it's now clear over the top again, and everything is fine. We went in and placed the implants. So that's the treatment protocol where we didn't lose any time, we didn't have to regraft, and everything worked out nicely. There is a protocol for infections that don't go away, but it's only used in cases where the graft material is contained. So you kind of have to have a scan, take a CAT scan at some point to find out if your graft material is contained or not, because that tells you what the next phase of treatment will be. So if your graft is contained and the symptoms are still there after you've done these other things, you have to consider partial or total graft removal. And there's a protocol from Loma Linda University by Mr. von Urban, an excellent guy. If you could get him here to lecture, that would be fantastic for you. Okay, where they do a partial clean out. So let me show you what the protocol is for that. You elevate your flap, take out collagen membrane if you have it there, remove the discolored graft material, flush the area out, make a doxycycline paste, an antibiotic paste, place it inside for a few minutes, take that out, scrape it down a little bit, there'll be a hard surface around the infected area, flush it out again, and close it. Don't put any graft material, don't put any new membranes. Just close it. Come back 6 months later, whatever your time interval was, the original part of the graft that remained will probably be intact. You'll place your implants and regraft the central portion at the same time. You've lost no time, and with the partial clean out, you still have the same outcome. So again, that's kind of what you see in these type of sinus graft infections. You see your graft material partially disappearing. Now here's a case where sinus was grafted with simultaneous placement of 3 implants. Okay, it looked very nice when they were put in, but there's a problem in opening over the middle implant. So there was an infection from the sinus around the middle implant. And you can see when the middle implant was removed, that middle area was debrided, cleaned out. Doxycycline paste was used, and it was closed. The final outcome for the case, the other 2 implants were fine. The area in the center partially refilled with bone. And instead of regrafting it and making a big deal out of this, the treatment plan was changed from 3 separate implants to a bridge with a pontic where the infection was. So there was, again, no time lost, and everything worked well with a partial clean out. Oh. If nothing seems to work and the graft is not contained, you have to clean up your sinus. And the way you tell if this is contained or not is by taking a CT scan. If you see the graft is scattered throughout the sinus, there's really not much you can do. And at this point, you're either going to have to clean up, take the implants and the graft material out yourself, or with the help of an ENT to clean out the sinus while you take out the implants. So at this point, it's a matter of cleaning the whole thing out. And that would involve functional endoscopic sinus surgery. So this is how you deal with this. And you can't just let this rest because you've gone through a series of things. By the time you're here, there's nothing left. If this is where you are, you have to just go back to 0. And it's not that that happens that often, but this is where this case wound up. The patient was put on antibiotics by 4 different people who did nothing but put her back on antibiotics again. And this is fun endoscopic sinus surgery with her sinus being cleaned out. And you see that an antibiotic is not going to fix what's happening in here. This is how functional endoscopic sinus surgery would work. You go in and they just clean it out. Okay, now, we look at this case, and I can tell you there was a case similar to this in Italy. This one also happened in Italy, where a lady was sent for almost 6 months back and forth between people who did nothing but put her on antibiotics that did not work. She ultimately wound up in the hospital where she lost the sight in her eye as a result of the spread of the sinus infection to the orbit. Okay, so when things are not, when the first stage is not working and the second stage is not working, you have to move very quickly to resolve the problem. So we made an algorithm to follow when you're dealing with a sinus infection. So you start out doing the procedure, either it works or it doesn't, okay? If after 3 weeks you've changed the antibiotic, you've done things like that, you've used the drain, it's not getting any better. At this point, you must take a CT scan to find out whether the graft is contained or not, because that separates your treatment in 2 different directions. If the graft is contained, you can try antibiotics again. Either it gets better or it doesn't. If it doesn't get better, you can do partial graft removal. Okay? If that works, fine. If not, you have to take everything out. However, if you take a CT scan and the graft is not contained, it's automatic that you're going to clean everything out because you're not going to make this better with antibiotics. So the key here is where the arrow is, that if you do not have a CAT scan by this point in the United States, that would be considered malpractice. You're not protecting your patient because there's something happening here and you have to figure out where it's happening. Is it happening all here or is it right here? Okay? And treat it accordingly. So what tips can I give you about sinus graft infection? Proper case selection, no pathology, no endo or perio problems around the sinus. There's a study that shows if you do sinus graft and ridge augmentation together at the same time, your infection rate will double. Why? Because now you have a membrane underneath your incision line. And if your incision line breaks down, you both are infected, your ridge augmentation and your sinus graft. So I tend to separate them. I'll do the sinus graft first, I'll come back and do the ridge augmentation later. Okay? That way I don't have that increase. Improper antibiotics, we spoke about that, starting it and continuing it. I use chlorhexidine for 2 weeks after the procedure till everything is closed. We rinse them out with chlorhexidine before we start. We use betadine on the skin. We hydrate my patients and hydrate my operatory every time. It's always draped, okay? Sterile draping for infection control all over the place. Okay, that may be the end of everything on this slide, okay? So remember I told you we use gauze. So when I'm not taking photographs and I don't want it to look crazy like this, here we're flushing out the sinus, here we have gauze, to keep the saliva away as you're grafting, because the patient is salivating and it's bringing in from, not just right from the salivary gland, but from the mucobuccal fold. So you're going and you have a possibility of contaminating your graft, okay? That's not the way to put graft material in. This graft material is going all over the place. The other one, it's a nice controlled procedure. You don't think about things like this, but if you see them side by side, there's a difference. Oh, don't do that. Okay, I think you get the idea. Again, it's Italy, so they put 2 membranes, 3 membranes, 7 membranes, 25 membranes. It's not necessary. Okay, more stuff. Remember we talked about making the incision lines away from the area of the window and away from the area of the membrane. So you have to think about, where is my window going to be, and make sure that your incisions are not going to be over it. That's automatically increasing your chance for an infection, okay? If the suture line breaks down over a membrane, that's why ridge augmentations fail. It should never be a problem with sinus grafting. Salivary contamination, we just showed the video on that. We talked about 2 surgical kits, one for the sinus instruments and one for the instruments that are going in the mouth. Keep your surgical time as short as possible. This does not mean hurry. what this means is have everything there. Have your graft material, your membranes, everything you need is right there so that you don't have to get it or send somebody to get it. It wastes time. And in medicine, they have studies that show the longer the procedure is open, the higher the infection rate. Okay? Because you're not working in a sterile environment in the mouth. You want to get in and get out quickly. After the surgery is over, I continue the antibiotics for 10 days. They're on chlorhexidine until the incision lines are healed. Okay. Alright. That's pretty much what I wanted to show you from here. This is. Forget about that, we're going somewhere else. Can't come home yet. That's the sheep study, by the way. I know it was in here somewhere. Membrane on one side, no membrane on the other side. Okay, in the sheep study, test 31%, 29%. Bone is pretty much exactly the same, whether you have a membrane or not. By the way, the test was the side with the membrane. It had a little bit more bone than the side without. Okay, so that just backs up the things that I was telling you before about okay to put a membrane in and okay that the Schneiderian membrane is not important as far as bone formation is concerned. This is another interesting technique that one of Dr. Cho, who I think has been here, Sang-Chun Cho from NYU has been here, and he just showed me this technique that he developed. They don't use it, but it's interesting. If he has a perforation, he puts in a thick double layer of Collatate, just puts it inside, he lets it stay there, and then he comes back a couple weeks later, and goes back in, and now the Collatate has been invaginated with soft tissue, and he just lifts up the Collatate and puts the graft material below it. So he started out with a thin membrane that perforated, now he's got a thick one. But it involves waiting and going in a second time, and it involves making the split thickness incision over the window. So it's a difficult procedure. I would rather, again, solve it the first time. Are you in the right place? Yeah, okay. This is an interesting concept. When you take out the molars and you look at radiographs later, doesn't it look like the sinus has gotten bigger? You take out the teeth and it looks like the sinus pneumatizes, that it gets bigger once teeth are out. I think everybody thinks that if you take out the teeth, the sinus is going to drop. Okay, but we did a study and to show that that may not be true. So let's look at some stuff. People will tell you that when you take out teeth, you should go in and do the sinus graft pretty much as soon as possible, because if you don't, the sinus will pneumatize and you'll need a bigger graft and you'll have less of the patient's own bone. But I don't know that that really is what happens. So I want to take a look at that. There was a study by a Korean group that looked at the growth of the sinus and when it gets to be its largest. And they found out that in males, the sinus reached its largest size in the 30s. And in females, the sinus reached its largest size in the 20s. And it doesn't get bigger after that. Here's the growth of the sinus, and the men in the 20s and women in the men in the 30s, women in the 20s, it's at its largest point. What happens after that? It's getting smaller, not bigger. So when you look at the study, it makes the thing about the sinus lumitizing after the loss of teeth sound a little bit strange. So, along with my friend Dr. Zadeh and Nita Baghshanian and Dr. Hamid, we did a study. It's kind of a little complicated one to see what happens when you take the tooth out, losing, say, one maxillary molar. So, if you look at the pre-op situation with the molar in place, you see that there's a certain amount of crestal bone, and when you look at later, after the tooth is out, there's not that much crestal bone there. So we're saying that, oh, the sinus lumitized and took away that bone. That's not what happened here. What happened here is there was loss of bone at the crest following the extraction. And that's why when you look at the radiograph, there's less bone. Not because the sinus got bigger, it's that the crest got smaller. It's a difference, okay? And we looked at that in a whole bunch of patients and took measurements as to where the bone was lost. So you look at, the before and the after here. I wish my pointer would work now. And you see the difference when the tooth is in place to when the tooth is out. And you look at the blue line where the floor of the sinus is, and it's not changing. The blue line, floor of the sinus, is almost at exactly the same position before and after. What's changing is the green line and the distance of crestal bone. The difference between the blue and the green line is what's changing, because the green line is moving up. Loss of crestal bone. And we looked at that, and it turns out that when you look at the mean loss, the mean height and bone reduction was 3.42 millimeters. Of that 3.42, 3 was due to crestal bone loss, and 0.47 was due to movement of the sinus floor. So in a percentage basis, that means that 88% of the difference was due to a change in the height of the crest, and only 12% was due to a lowering of the sinus floor. So that's pretty much a myth. It's something that doesn't really happen. But when you look at it, what you see is more sinus, but what you're really seeing is less crestal bone, and it makes the sinus look bigger. But that floor line does not change. Interesting. And we looked at all the different things that could possibly affect this, and none of them, the root width, the proximity of the root to the sinus floor, periapical lesion, thickness of the sinus membrane, none of that made a difference. None of it. The only thing that was different was the change in the height of the crestal bone, and that was 88% of the change. This just got accepted for publication. It'll probably be will be out in July. It'll be published. So what's the significance of this? When you lose that vertical height of bone, that changes your treatment plan, right? Because if you have less than 10 millimeters, now you have to put in a short implant rather than a regular implant. If you have less than 6, now you need some kind of a sinus augmentation. So what this means is you don't have to do the sinus graft quickly. What it means is you have to do the root, procedure, quickly. You have to do a ridge preservation procedure quickly to prevent that loss of bone. And then your treatment plan option will not change. Okay? You immediately do ridge preservation, you'll still have your 10, or your 8, or your 6. If you wait, you'll lose 88% of that height, and it will change the necessary procedure that you have to do. So, it's an interesting study. Okay? So, what else can I talk to you about sinus grafts? We're talking about a million different things. So, by raising hands here in the audience, How many of you are doing now lateral window sinus graft procedures? Not a lot of people. Okay, how many are doing crestal? Okay, I want more of you to do this. Okay, all right. So, since you're all, most of you beginners, I think this is very important because ultimately you're going to have to do your first case. And when you choose the case you're going to do, you should choose an easy case. One that is not going to result in failure because you don't have a lot of experience. So what we did is we put together something called the Maxillary Sinus Difficulty Score. And what it is, it's not telling you that you should or you shouldn't do anything. It's really meant to show you what things you should be looking at to determine whether it's an easy or a difficult case. Because, you know, when you look at a CAT scan for the first time, you're looking at, oh, do I have enough crestal bone to place an implant? That's all you see. You're not looking to see if there's an artery in the lateral wall. You're not looking to see if there's a cyst. You're looking at the thing you know, not the other things. So the purpose of this is to make you familiar with the things that you should be looking for to determine whether the case is difficult or easy. And then we simply add up a bunch of points to find out whether it's a simple or an easy case. So we look at different things. We look at, you know, the height of a patient's face. Do they have a tall face or a short face? Tall face, easier to work on than short face. Short face, maybe more muscles, less bone, very difficult to retract. So for those reasons, you make more points for short face. Mouth opening, can they open wide, or are you going to have a difficult time getting in to see? It's going to determine how effective you are. What type of edentulous are you looking at? It's easier to do a sinus on a completely edentulous patient than it is a patient who's only missing one tooth and you have to work in a very difficult partial site. So you give points for each of those differences. The thickness of the wall when you're trying to make your window. Thick wall involves more grinding, more changes, you know, possibly more difficulty. The thickness of the membrane. If the membrane is very thin, you have a greater chance of perforation. So you have to, you know, here give it more thought and more points. Septum. If you have a septum that goes from lateral to medial, that's an easy one. If you have one that goes from anterior to posterior, that's kind of difficult, okay? If you have multiple septa, that's even more difficult. So based on what you have for septa, you give that points as well. Is the septum in the anterior region where it's narrow and difficult to work on, or in the posterior? Different points. The artery. If there's no artery, that's easy. If there's a very big artery and you have to deal with it, gets more points. Okay? And then there could be a big artery, but if it's not in the area where your window is being made, then that's not a particular issue. It doesn't apply. But if you have a 3 millimeter diameter artery right in the middle of where you're doing your window, and you have magnifying loops on, that's going to look to you like an aorta. Oh, it's going to be huge. So you have to be able to do it. And we again many times talked about the angle between the medial wall and the lateral wall, you know, making the window more difficult, and the perforation rate being higher. There's also something, the zygomatic process. If you put your finger in your mouth, which is, you know, you're not supposed to be doing in company, but if you look up here, over the first molar is the thickness called the malar eminence. And if you have a lot of crestal bone loss, the malar eminence is right by the crest. And instead of working on a lateral wall, you're working on the bone that's going out at this angle. And that's very difficult to do a sinus elevation. In a case like that, that's the one on the right side, where you have that thickness of bone by the first molar. Limits how you can make your window. On the medial wall of the sinus, sometimes you have an indentation where the alveolar crest meets the medial wall of the sinus. So the medial wall of the sinus comes down, and then the alveolar crest is here, and sometimes there's a V-shaped notch back there. And if you're thinking about a V-shaped notch, and you're trying to elevate the membrane out of that notch, you kind of get stuck in here. And if that angle is like that, you're never going to be able to do this, okay? And you see the notch on that side is quite severe. So again, it's a matter of recognizing that that's a problem, and here giving it more points, okay? So what you do is you go through this whole thing, and you add up the points, and this is really subjective, okay? But if you go through this whole identification process, it means you've looked at all the things that are important for studying a maxillary sinus graft. Okay, I've looked at everything, I've identified all of these things, and this looks like it's going to be an easy one, or this looks like one I want to send to somebody else to do. And that's the only purpose of the difficulty score here, is to give you an idea of where to look and to add everything up and see if this is one that you want to do. So we've done a lot of stuff here today, and we've looked at almost everything that I could think of that's important. I have some more stuff that we can talk about. And we have time, so I think we're going to do it. What? It's 4 o'clock, right? We have an hour. Well, how long do you want to leave for questions? Well, so I think the questions and answers we have, and if you still have time, okay? All right. We had a big conference, okay, and what we're going to do is we're going to do questions and answers on everything we've done so far now. And if there aren't a lot of questions and we can answer everybody's questions, then I'll go on and show some additional stuff on short implants and the difference between short implants and other techniques. So we have our team of interpreter and microphones, so we can, if you'll come up, we can do our questions and answers. So think of good questions. Okay.
Dạ, giáo sư Stephen Wallace kết thúc nội dung chương trình của mình hôm nay ạ. Thì bây giờ các bác sĩ là có thắc mắc nào mà có thể giơ tay để cho anh biết nói.
Great, so if anybody has a question, raise your hand.
Quý ai có câu hỏi thì giơ tay để cho anh chị.
Xin phép ta hỏi một câu thì nâng xoang thở, về nâng xoang thở hồi nãy thầy nói rất là nhiều vấn đề, nhưng mà thầy không đề cập tới cái vấn đề mà bản thân mình thắc mắc và cũng nhiều đồng nghiệp đã thắc mắc. Khi mà bệnh nhân bị viêm xoang và mình điều trị cả năm, nhưng mà cái màng xoang nó vẫn trên 7 nó dày 7 ly, mà cũng có trường hợp, tôi cũng có những giáo sư họ nói là dưới 3 ly thì mình nâng xoang. Như vậy hỏi giáo sư, khi mà sau khi mình điều trị uống đủ kháng sinh nhưng mà nó vẫn như thế thì có thể là nâng xoang hay không? Và mình cũng đã tham khảo trong group có những người mà dày trên 10 ly, nhưng mà họ họ vẫn nâng son và thành công, và bản thân mình thì mình chưa dám làm những chuyện đó, nhưng mà mình chỉ có là một trường hợp cho người thân và nó cũng thành công. Như vậy xin giáo sư cho mình lời khuyên khi mà mình điều trị mà viêm son nó xuống cái màng son nó dày thở bao nhiêu ly thì mình được phép nâng son thở.
Yeah.
Xin cảm ơn.
He would like to ask about the sinusitis and after medication treatment and the thickness of the sinus, the synovial membrane. How much is the maximum thickness we can start to do the bone the sinus graft, and what is the thickness of the sinus we can
Right. Just like anything else in sinus grafting, there's no absolute rule.
thì cũng giống như mọi thứ khác thì cái việc
How
không có quy tắc
thick or thin something should happen to be. What you're looking at is absence of symptoms. Patient had a sinusitis. Sinusitis was treated. Patient is not having a recurrence. Patient is healthy. Well, maybe the membrane is 3 to 4 millimeters in thickness. You make sure your scan goes up as high as the ostium. Okay.
the high of the ostium.
Yes, and look to see if the ostium is patent and there's no inflammation around there.
Yeah.
And then you elevate the membrane and you tell a patient that you may be at risk for a possible problem because you're of the thickened membrane. But I've done that with membranes that are 10 millimeters thick. Okay, as long as there are no symptoms. Okay, so
Thì chúng ta cần phải có là không còn triệu chứng nữa, chúng ta xem cái vị trí của cái lỗ xoang á, cái lỗ ostium á, nó so với cái mức mà chúng ta được nâng xoang thì chúng ta thấy còn 3-4 ly á, là cái bề dày chúng ta có thể làm. And would you have ever do the sinus graft when thickness of the synovial 10?
I may have. Okay, I wouldn't want to, but I can. If my patient is symptom free, or
Không có triệu chứng, 10 ly mình hỏi lại thầy để 10 ly á, có khi nào thầy làm không? Thì kêu có, khi bệnh nhân không có triệu chứng.
and I don't see any dental-alveolar etiology that may be causing that thickness that I could treat.
Yeah.
Okay, if there was something I could treat to make that go down, I would treat it. If I see nothing, okay, I will go in there, under certain circumstances and work in a less than ideal condition.
Trong những trường hợp mà không có lý tưởng á, thì cái màng xoang và you look into what alveolar dental condition, what the alveolar dental condition you look into
Oh, infected teeth.
và không có cái sự nhiễm trùng ở trong cái răng xương ổ, có bề dày xoang, không có triệu chứng thì có thể là nâng xoang. Nhưng mà thầy có nói là luôn luôn nói với bệnh nhân về cái nguy cơ có thể nó bùng phát cái nhiễm trùng sau khi mà mình làm cái thủ thuật như vậy.
So what I'm saying is if there's an active cause for that, it's going to get worse. If there's no active cause, it's a scar for something that's happened before. And I may not be able to get it any better than that unless I have an ENT go in and clean out the whole sinus and start from scratch. That's your other option. You make a decision. I don't like the way this looks. Go to the ENT. They'll clean out the entire sinus. A new thin membrane will form, and then you go do your sinus lift then.
Thì có thể mình chọn một cái cách là mình nhờ bác sĩ tai mũi họng họ giải quyết cái xoang của mình, làm giảm cái bề dày của xoang, rồi thì chúng ta là có thể là nâng xoang an toàn.
Okay. Questions? What about that? No, yes. Nobody on this side of the room is asking questions. Yeah.
Cái tỷ lệ thủng màng xoang á, thì thấy nhiều nhất là khi cái góc cái lớp cái thành ngoài và thành trước màng hẹp. Thì theo thầy thì khi nào thì mình sẽ ghép cái góc màng xoang tới tận thành trước thì nhiều cái tỷ lệ cụ thể.
And as far as we know, the risk of the perforation when we do the elevation at the position between the lateral and the anterior wall, the position of the elevation very risky for perforation. And when when we should elevate to the anterior wall, the visual wall of the sinus, and
Yeah.
what indicator that we should stop to prevent, to avoid the perforation when we have a very risky position of elevation.
I don't stop. If I can see on a CAT scan the anatomy that I have to deal with, I find a way to deal with it. And I know before I go in how I'm going to do that. For example, let's say your septum is running from anterior to posterior, not from lateral to medial. You start to elevate your membrane, and all of a sudden, you can't get in. So, because there's a septum going up here, and I can't get here. I take my piezo, and I cut the bottom of that septum, and I elevate that piece of bone with the membrane. I can do that because I knew it was there before I started, and I made a window that allowed me to see it all. So I'm not blind. I see exactly what's there, and I do it.
Dạ thì thầy ông nói rằng mình cần phải xem cái CT để mình biết được cái hình thái, để mình biết được cái hình thái thì mình sẽ chỉ các cách mà mình làm. Ở đây thầy phân biệt là có một cái vách xoang nó chạy theo chiều trước sau, chứ không phải là chạy theo chiều ngoài trong. Thì mình có thể bóc tách đến cái vách xoang đó. Khi bóc tách xong rồi thì mình có thể là mình cắt cái vách đó rồi mình đi tiếp. Cho nên là cái ý thầy nói là chúng ta bây giờ cái hình ảnh học của chúng ta biết được hình thái của xoang để chúng ta có thể là bóc tách mà chúng ta không có nguy cơ bị lủng cái màng xoang.
So should we always elevate the membrane to the anterior wall?
Yeah, on side we should be elevate to the medial wall.
Anterior one I'm talking about. Well, usually the first implant that you're putting in is right there. So you probably have to. There may be a situation, let's say you look at that area and the crestal bone in that area is 1 millimeter thick. Too thin for implant. Maybe you'll put an implant in front of that. You'll elevate the sinus posteriorly where the ridge is wider. You don't have to go anterior because you're not placing an implant there. So here in front of the sinus and back of the sinus, you make a bridge.
Yeah.
So if you can avoid that area for an implant, then you don't have to go there.
Mình chỉ bóc tách đến cái thành gần á, chỉ khi nào mình cần đặt cái implant ở đó thì có một cách á, là có thể mình lập lại kế hoạch điều trị, có thể là mình đặt một cái implant ở ngoài cái xoang rồi mình dời cái vị trí đó ở đây thì mình không có phải bóc tách tại chỗ cái ngách mà nó gần cái màng xoang, và mình có thể làm một cái cầu răng ở cái từ một implant cắm ở ngoài xoang và một implant ở trong xoang và mình lùi phía sau để mình khỏi phải đi vào cái thành phía gần ở chỗ nó rất là hẹp và nó có cái nguy cơ nó bị là thủng cái màng xoang. Dạ, có sự tiện.
I have a question for you that it's amazing to see, to hear that 88% of the bone loss at post-extraction is not because of sinus neurotization. We have believed for a long period of time that the sinus neurotization is the cause of that we don't have enough bone implant placement. So, if according to your studies, 88% of the cases, so should we choose between sinus augmentation or only bone grafting? Because if you said that the most cases are caused by the bone loss after dissection, so I think that if the main cause is about bone loss, so we should do only bone grafting instead of sinus
No.
grafting, right?
No.
Yeah, thì let me translate the question. Thì vì cái tỷ lệ nghiên cứu của nhóm thầy á, tỷ lệ khi mình nhổ một cái răng vào á thì 12% là tích khí nó tăng lên để nó làm giảm chiều cao của xương ở dưới đó, 88% từ phía ngoài. Thì thầy mới nói rằng là chúng ta sẽ chú trọng vào việc mà bảo tồn cái xương hổ. để chúng ta giữ cái chiều cao. Cũng như vậy thì bác sĩ Tiên câu hỏi là nếu như vậy thì cần chi năng xoang lo mà làm cái xương ở bên ngoài chứ đâu có cần phải lắng vô cái xoang chi. Thì cái ý nghĩa của cái chuyện mà nâng xoang là chủ đề của này nó trở thành rất là lấy cứ lo ở ngoài to ghép xương bên ngoài chứ không phải là gì lắng vô cái xoang. Các anh chị nắm được cái ý đó không? Yeah.
Okay, so being able to identify that the bone loss is due to crestal bone loss means that immediately after the teeth, socket preservation is more important than sinus augmentation. To save that bone, okay? If the bone is already lost, if you're dealing in the posterior maxilla and aesthetics is not an issue, in other words, tooth length, the simplest procedure to get new bone is a sinus augmentation.
Yeah.
The most difficult procedure to get new bone is vertical ridge augmentation. By far, the most difficult one is vertical ridge augmentation.
Dạ, thì cái ý nghĩa của nghiên cứu thầy là để mang tính dự phòng, tức là khi chúng ta hồi nào đến giờ chúng ta nghĩ là khi chúng ta nhổ răng mắc răng thì xoang nó sẽ tấn công ra bằng cái hiện tượng gọi là pneumatization và tiêu xương ở bên ngoài, nhưng mà nghiên cứu của thầy thấy rằng là ở trong nó ra 12% mà nó tiêu từ dưới lên trên tới 80% là để chúng ta nhấn mạnh cái vai trò mà chúng ta phải bảo tồn xương ổ. Nhưng mà tuy nhiên á, ở những cái mắc xoang mà lâu ngày rồi á, thì một đó là chúng ta phải ghép xương ở phía trong, ghép từ trong ra, ghép màu xương. Hai là chúng ta nâng xoang thì cái phương pháp mà nâng xoang á nó rất là dễ thực hiện và nó có tỷ lệ thành công cao, và nhất là vùng phía sau thì chúng ta không có sợ về thẩm mỹ, bởi vì khi chúng ta nâng xoang là chúng ta lắng lên trên, và như vậy á, thì cái chiều cao của mình của chúng ta rất là nhiều, thì á, là chúng ta chấp nhận cái đó vì nó không liên quan đến thẩm mỹ, và cái thủ thuật nâng xoang á, lắng vào trong nó dễ hơn là chúng ta nâng xoang theo chiều đứng. Bởi vì đến bây giờ á, cái nâng xương á, theo chiều đứng là một trong những thủ thuật là khó nhất, và cái tỷ lệ mà thành công cũng như tính tiên đoán của nó rất là thấp. Tôi nhớ đến cái câu hỏi của bác sĩ Huỳnh Đại Hải. Bác sĩ Huỳnh Đại Hải nói rằng là mình không lắng vô trong á, mình phải ghép ở ngoài á, mà mình không đủ vào các chiều xa. Thì nhân đây cũng xin hỏi với thầy. And this question makes me remind me of the question of one doctor. He asked me during the coffee break time. This may be not relevant to the topic we are discussing now, but his question is that instead of grafting bone sinus graft, if he would like to have the vertical augmentation, but he doesn't know, the patient doesn't know have a good piece of tissue to have to cover the graft material, and how can he do that? Before he is afraid that the ground end is very high if we do the sinus graft and taking no care of the vertical augmentation.
Yeah, so it's exactly what I said.
Và chính xác như chị tôi đã nói.
When you do any change in the shape of the ridge, it needs covering it with soft tissue. The sinus graft, you open and you close exactly the way you found it. No periosteal release, no moving tissue around. For ridge augmentation, you have to cover it, and you have to cover it tension without tension. So you have to get soft tissue from somewhere. And that is dependent upon your ability to release soft tissue. And a person who does that very well is Esteban Urban, who I mentioned, lectures about usually horizontal and vertical ridge augmentation, and he's excellent at releasing flaps, and he gets all kinds of tissue.
Yeah.
My son is an oral surgeon. My son gets tissue by taking palatal flaps and turning them around and repositioning them. So the tissue is there, but it's not as easy as doing the sinus graft, where you have to move nothing. You make a hole and you fill it.
Yeah.
Okay? The problem is your teeth will be long, okay? And if the maxilla resorbs up and in, and your lower teeth are out here, now you've got angles to get from here to your lower teeth.
Yeah.
So you have you have prosthetic issues to deal about.
Yeah.
And always restoring the form of the original form of the maxilla is always the best solution. The question is it worth it? And do you have to in a given case?
Dạ. Thì như thế này các chị, khi chúng ta mắc răng ở phía sau thì có hai cách mà chúng ta có đủ xương để đặt implant. Một á, là chúng ta tái tạo lại cái chiều cao của xương bằng cách chúng ta nâng xương theo chiều đứng, đó là một việc rất là khó. Hai là chúng ta lắng vô xoang, giống như là chúng ta lắng biển gì đó, chúng ta lắng xoang cắm implant và chúng ta chấp nhận là cái thân răng chúng ta phục hồi rất là cao. Thì á, nếu như chúng ta ghép xương theo chiều đứng á, thì chúng ta gặp cái khó khăn là chúng ta phải có được cái sự mô mềm để bao trùm cái đó. Một cái chuyên gia nếu mô mềm thì nó có ở đâu đó khắp nơi trong miệng, nhưng mà muốn làm như vậy thì cần phải có cái khả năng, cái trình độ, cái khả năng mà quản lý mô mềm. Chẳng hạn như con trai của tôi là bác sĩ phẫu thuật miệng, là anh đó, anh con trai của thầy, anh có thể lấy cái mô mềm từ cổ cái anh quay ra và để anh tạo ra cái mô mềm đầy đủ để anh nâng xương theo chiều đứng và anh ghép. Còn có một người nổi tiếng nữa là Ispan, ông đưa ra nhiều cái cách để chúng ta quản trị mô mềm, để đưa ra nhiều cái mô mềm để nâng xoang. Cho nên bây giờ á, quý vị phải chọn một trong hai cách, cái nào mà dễ dàng nhất. Nếu như chúng ta muốn nâng xoang là chúng ta phải có khả năng bóc tách và làm cho cái vạt nó giảm căng. Cái chuyện đó là tùy thuộc vào khả năng của anh chị. Nhưng mà nâng xoang á, chúng ta thấy không cần phải là giảm vạt vậy, vì chúng ta nâng một tròn. Chỉ có cái khó là gì? Đừng làm hết cái màng xoang thôi. Còn lại á, chúng ta đặt vạt bình thường, tạo cái lỗ, rồi á nâng cái màng lên, đừng có rách, bỏ vô, đừng có nhiễm trùng, và đẩy lại, không cần phải giảm căng, không cần gì hết. Thì nếu như cái đó nó dễ dàng thì chúng ta phải chấp nhận là cái phục hình nó phải dài hơn. Còn một vấn đề nữa mà cái nâng xoang nó dở là bởi vì sao? Hàm trên của chúng ta tiêu xương hướng tâm và cái bề ngang của chúng ta là hẹp. Nếu chúng ta chỉ chọn cái cách nâng xoang thôi thì chúng ta sẽ có được đủ chiều cao xương để đặt implant, nhưng mà chúng ta không có trả lại cái chiều ngang đúng. Và như vậy á, chúng ta làm cái phục hình nó khó khăn cho bác sĩ phục hình. Nếu làm đúng trục thì sao? Cắn chéo, và nếu không thì là gì? Cái răng nó nghiêng ra như thế này, nó không đúng cái hướng của cái sinh cơ học mà của cái răng. Đó là tùy mỗi cái nó cũng có những cái vấn đề của nó. Như vậy thì mình trả lời câu hỏi chuyện trước rồi chúng ta sẽ xem xét những cái câu hỏi nào từ đến đây sau.
Get back to you people again. Okay.
Trường hợp này
One question from back there.
Dạ, cậu có thầy cũng các chị đưa mic ra vào bên kia, thầy nói rằng cái khu vực này được ưu tiên quá, cho nên để cái số bên kia được hỏi đấy.
Như vậy là đây như vậy là mình kê vào con xương ổ trắng thì mình còn đi ngay như vậy là kê rồi. Nhưng mà có những trường hợp về cái kháng giải phẫu, có những trường hợp như ổ trắng là thông xoang. Thì thông xoang ở trường hợp không nhiễm trùng thì mình sẽ xử lý như thế nào để có con xương ổ trắng lúc đó. Còn thứ hai, những trường hợp có nhiễm trùng thì mình sẽ xử lý làm như thế nào và bao lâu thì em sẽ phải hiểu này.
So sir, you place emphasis on the risk preservation to have enough work to place the implant. But his question here about the oral and communication happen during the extraction. And if he remove a tooth and have the oral and communication, one condition is with the inflammation and one condition without complication. In the two situations like that, how would you address to keep the bone not resorption for the future implantation?
Okay. Well, I can show you how to first to learn how to repair oroanterior communication. You go back to oral surgery specialty program for 3 years. That will be the best way to do that. I'll show you a video on how one person does that. It's difficult. A lot of times you can do it easy with a sliding flap, and you slide a flap, you may place a membrane, slide a flap over it, and if you get good suturing, that should work to close it over. Now you have to find a way to go in with split thickness flap to do your sinus graft.
Thầy ông nói cái này nó thuộc cái phạm vi của cái phẫu thuật viện á, nếu như mà muốn nhổ răng á mà nó không có thủng mà nó thủng xoang rồi cần phải che lại cái thông giữa miệng và xoang á, thì là cứ quay về cái bộ môn mà oral surgery tầm 3 năm đi rồi sẽ biết cách mà làm. Nhưng mà nguyên tắc chung là chúng ta phải kiếm cái vạt, chúng ta phải kéo cái vạt đó trượt lại để che cái lỗ thông đó, nhưng mà nó không nằm trong phạm vi ở đây mà nó nằm trong phạm vi của cái bộ môn mà oral surgery là phẫu thuật miệng.
So the first thing that you have to do with the ororectal communication is clear off the epithelial tract that is holding this open. You also have to do whatever you can to get rid of any infection inside the sinus, because if there's an infection, it's going to want to drain out through that area and it won't close. So you're on antibiotics, you're flushing the sinus out, and now you start the surgical procedure by removing the epithelial tract.
Thì khi chúng ta bị thông cái miệng và xoang á, thì có khuynh hướng là cái biểu mô nó chui vô ở chỗ đó, và muốn chữa một cái sự thông miệng xoang là làm cho cái xoang với lại cái khoang miệng của mình cách ly với nhau. Việc đầu tiên chúng ta phải lấy đi cái biểu mô rồi đó, rồi chúng ta bóc tách, chúng ta phải rồi chúng ta ghép, chúng ta kéo lại để chúng ta che cái lỗ thông đó. Cái đó là thầy gọi là epithelial tract, một cái bẫy mà bằng biểu mô, phải lấy sạch cái biểu mô đó ra, rồi bóc tách để mình tìm một cái vạt kéo mình đóng.
This is basically a procedure that an oral surgeon would be comfortable with.
Đấy là một cái kỹ thuật mà các bác sĩ phẫu thuật miệng họ rất là thoải mái, họ là chuyên ngành của họ trong việc mà làm mấy cái này.
Because you have to get a lot of tissue mobilized, and you are going to use the buccal fat pad to close over this.
Thì chúng ta còn phải có một cái sự di động của vạt rất là nhiều để che cái lỗ thông đó lại. Thì chúng ta còn phải lật vạt ra, vạt lớn kéo nó giãn ra để chúng ta có thể kéo đóng.
They're opening that up because they're going to tuck the fat pad underneath that palatal flap.
Chúng ta còn phải lật vạt ở phía sau, thì thấy bóc tách ở phía trong để chúng ta đưa cái vạt từ phía ngoài nó đi vào, nó trùm vào ở trong cái chỗ mà chúng ta bóc tách ra để cho giữ cho nó kín cái lỗ thông.
So again, removing all the epithelium.
Và đây là bước mà chúng ta lấy cái biểu mô mà nó lót vào cái lỗ thông giữa miệng và xoang.
Or getting it out of the way.
Và chúng ta lấy nó ra hết, lấy cái biểu mô mà nó đã nằm ở trong cái lỗ thông.
Right, it's clean already. Go do something.
Dạ, khi làm sạch rồi thì chúng ta sẽ làm cái điều gì đó để biết nó lại.
So the opening is fairly large.
Và cái lỗ mở thì tương đối lớn.
just getting the bony walls exposed.
Và con phải làm cho cái thành xương nó được lộ ra, thành xương của bóng nó lộ ra.
So you do a soft tissue closure.
Chúng ta khâu cái một mềm trước.
If you're really brave on this procedure, you close that soft tissue, elevate the membrane up, graft it, and then close over the top.
Và sau đó chúng ta bóc tất cả các bạc ở bên ngoài ở phía trong miệng và chúng ta khâu nóng lại.
Okay, now splitting the periosteum
Dạ,
up in the area of the mucobuccal fat pad.
Dạ, đây bây giờ chúng ta là cắt cái rạch cái màng xương để chúng ta tăng cái độ đàn hồi của bạn để đóng lại từ phía trong cái miệng.
Once you find the fat pad, you will know that you found it because it's just going to want to come out.
Dạ, chúng ta cần
There it is.
cắt
See
cái
it?
màng xương để chúng ta thấy đó.
Notice it's not cutting up there, it's spreading because there are blood vessels up there. And if you go in there and cut, it creates too much bleeding.
Khi chúng ta cắt như vậy thì máu chảy rất là nhiều và
So now you
có
just
thể
pull it out.
chúng ta có cái nguồn cung cấp máu để nó nuôi. Any changes of the morphology of the cheek if we remove the buccal bag?
I haven't seen it. Yeah.
Dạ. Thì mình có hỏi là có thay đổi hình thái của má khi chúng ta cắt với cái khối mỡ má như vậy thì kêu không thấy, không thấy nó đổi cái hình thái má gì chuyển thành lớn như thế này.
But you have quite a bit of tissue in there. Yeah.
Thì ở đây có rất là nhiều cái khối mỡ nó lớn đó.
And you see how he's now tucked it under the palatal flap.
Và
That's
chúng ta
the suture.
không tới cái màu má để trên đó.
His hat. He's gonna just keep going all the way across.
Và cứ tiếp tục như vậy.
Went too far. I don't know how far to move this. We're sutured in now. Goal is for a suture.
Chúng ta khâu chúng ta đừng đục cái lỗ để chúng ta khâu xuyên qua cái lỗ sườn này.
And now you can suture that down.
Và chúng ta có thể khâu nó xuống dưới cái nách của đây.
There's no periosteum to suture to, so make a hole at the bone and suture it directly to the bone.
Cho nên ở đây có cái màng xương để chúng ta khâu vào, cho nên đục một cái lỗ để chúng ta có một cái điểm tựa để chúng ta khâu vào.
So now you remember that big flap that he made at the beginning that went all the way up to the lateral? Now you're going to take that and bring it over.
Và bây giờ là cái lớp cũ mà bên ngoài phải bóc tách cho vùng cổ lên đóng kín hết lại tất cả cái vết thương.
Pretty neat.
Dạ, như vậy còn câu hỏi nào nữa không ạ? Ở phía bên kia xin cho micro ở phía bên kia thì ông thầy muốn trả lời những câu hỏi ở cánh bên kia. Chúng ta có 7 câu hỏi được bằng giấy đây thôi. Nên xin chúng ta trả lời những câu hỏi miệng trước rồi chúng ta sẽ hỏi những câu hỏi giấy bên sau.
Professor, I have a question for you. In this case, if about blood vessel, if it is and within the lot, would specific protocol would you like follow or any case or just carry on with grafting and gloves? Nghĩa là em hỏi là ví dụ như mà trong trường hợp thầy nói là về cái chảy máu á, thì nếu mà nó chảy máu quá nhiều thì có cái phác đồ gì đặc biệt để trong trường hợp đó không, hay là chỉ là đơn giản là rách xương hoặc là rồi khâu lại thôi.
Em đang nói trong năng xoang nè. Yeah. And he wants to ask about how to control the blood bleeding. If the earth control bleeding, how we control the bleeding during the silent part. Xin đặt lại câu hỏi là thầy có thể chỉ cái cách mà chúng ta kiểm soát cái chảy máu trong trường hợp mà chảy máu không khó kiểm soát được trong khi năng xoang.
See if I can find this.